tardes.
Good afternoon, everyone, and welcome to the 8th webinar as part of the Puerto Rico Outreach Webinar Series. This webinar in particular is in collaboration also with the Hispanic Alliance of Clinical and Translational Research, and also with our colleagues at the U54 Dataomics. We thank you all for taking time today for attending this presentation. My name is Vivian Colon. I am professor at the School of Public Health and also investigator of the UPR Cancer Center. Before we started, just a quick announcement. This webinar will be recorded. During the webinar, please mute your Zoom line so we can hear the presentation as well as we can. Answers, please, at the end of the presentation. In the meantime, you can type your questions in the chat. And also, as a reminder, an evaluation survey will be sent from our colleagues at the evaluation board of the U54 to all the attendees. Please let us know what your thoughts about this webinar and how can we improve future disseminations. So today I'm glad to present my colleague, Dr. Maria Fernandez. She is the Lauren Bain Distinguished Professor in Public Health and Medicine at the UT Houston. She's also the director of the Center for Health Promotion and Prevention Research at the University of Texas School of Public Health. Maria is an expert in the field of implementation science, which has currently several projects in the area at her institution, but also in partnership with different centers and institutions in the United States. But most importantly, Maria Fernandez is, along with me, the co-leader of the Puerto Rico Outreach Core at the University of Puerto Rico, MD Anderson. This partnership has been for more than 10 years, and Maria has been a very important part of the development and growth of community outreach and cancer control in Puerto Rico. So that's why I'm very glad today to present to you Maria Fernandez, which will discuss with us the importance of implementation science in cancer research. So with that, I'll pass the presentation to Maria.
Thank you, Vivian. Just one moment. Let me make sure I can do this. And if you could just confirm that you can see my screen.
Yes, we can.
Great. Thank you. Thank you, Dr. Colon, and thank you very much for the nice introduction. It's been my pleasure to be part of the U54 in Puerto Rico and the outreach core. I've really learned a lot in my work there and with the team in terms of not only community engagement for cancer control, but also what I'm going to talk about today, implementation. I'm going to give the presentation in English, but I'm happy to answer questions in Spanish. And if there are any pieces of this that you'd like me to talk about more in Spanish, I'm happy to do that as well. So I'm going to talk a little bit about dissemination and implementation frameworks, some fundamentals, and then talk about how do we optimize evidence-based cancer control interventions. I'm going to talk a little bit about intervention mapping, and a little about program adaptation, but primarily about talking about strategies and how we select strategies. So I like this quote by Khalil Gibran, which is, "A little knowledge that acts is worth infinitely more than much knowledge that's idle." And as we all know, there's a lot of really great and efficacious solutions in cancer control and cancer prevention that often fail when implemented again or when implemented in the real world. So sometimes they'll work in a research study, but then when we go into the real world, they're not as effective. And so we're aware of examples of knowledge that is idle. Implementation science provides us with methods and tools to not only better translate knowledge to practice, but also to design interventions with an eye towards successful implementation and dissemination in the first place. So some of you may have heard about this research to practice gap, and what do we mean by that? And this is partly the time it takes for new discovery or effective intervention to be implemented as usual care or standard practice in the real world. This is from now a very cited study over 20 years ago by Ballas and Boren that looked at this pathway from original research to implementation. And here you can see that of original research, a lot of it is negative results that then don't get published. Even after publication, there's lags in times from when those publications result in ultimate guidelines for practice or reviews for public health interventions, and then implementation. So it's estimated that it takes about 17 years to turn 14% of original research to the benefit of public health or to the benefit of patient care. And I've heard researchers who'd like their ideas to impact practice, and they complain when those ideas don't get used. And practitioners, they might say that practitioners are not aware of those or should be using them. But I think that the problem lies in several places, including what researchers are doing and not doing. Way back in 2002, which is when the National Cancer Institute had what some folks think of as the very first meeting related to D&I research for cancer control. And it was a really, I actually was there, and it was a really important meeting for me because, among other things, I met some of the key folks in the field of implementation science, some of whom I still have collaborations with today. And one of those people who unfortunately has passed away was the developer of the diffusion of innovation theory, Everett Rogers. And so there was a lot of talk about the fact that, and he developed that theory in the 1950s. So there's a lot of talk about how if we've known about diffusion and the importance of implementation and dissemination, then why isn't it happening? Who's responsible? And one of the things that they did at that meeting was they broke us into different groups where researchers went into one room and funders went into another and practitioners went to another, and they said, who do you think is responsible for bridging this research to action gap, right? For making the products of research actually usable. And when we came back together after each groups had discussed, every group was sort of saying that it was the other group's responsibility. And so a barrier to translation of research related to cancer, but certainly other types of research, is that people feel like the responsibility for dissemination lies elsewhere. I would say that that's changing. However, I think that there does need to be a lot of work in this regard. I put this picture here because this is actually a success story. This is the Coordinated Approach to Child Health, or CATCH, which is a multi-level intervention aimed at improving diet and physical activity among children. And this was a program that has been widely disseminated. And in fact, there's even policies that have been put in place in schools to include programs like CATCH. But the point of this slide really is to underscore the fact that it's not just the effectiveness of an intervention that is important for ultimate impact, but it's also the reach, the extent to which it reaches the largest population possible that could benefit from it. And so when we think about the impact of our work for cancer control, we have to think not only about its effectiveness of the strategies, but also their reach in the population. We know that if you build it, they won't necessarily come. And therefore, we have to think about how do we make them come? How do we make our interventions usable so that they are relevant for the real world? The latest research shows that we really should do something with all of this research. The NIH, when they first came out with a program announcement of research, made this statement in that PAR, and that was that closing the gap between research discovery and program delivery is both a complex challenge and an absolute necessity if we're to ensure that all populations benefit from the nation's investments in new scientific discoveries. And I think that to a large extent, many researchers and others have sort of bought into this and are now supporting more D&I research and looking towards existing studies, even if they aren't specifically dissemination or implementation research, but looking at how we can have considerations about implementation and dissemination even from the beginning as we develop our research studies. So first, a definition: implementation research is the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical or community settings in order to improve patient or population outcomes. Dissemination research is the study of targeted distribution of evidence. So think of like this is implementation research is sort of like how you get it used and the strategies for getting a practice or an intervention or even a policy used. And dissemination research is how do you do scale up and spread. It's important to recognize that implementation science is inherently multidisciplinary. And because of the overlap of many different fields, there's also a lot of confusion with many different terms. And so you may hear of terms like improvement science, quality improvement, health services. These are all sort of overlapping terms, and And I have them here situated. This is from a slide from David Chambers. But some people might put these circles in a slightly different way. It's important, though, to understand that because it's a multidisciplinary, and I would say interdisciplinary field, that it's important to work with people from different expertise. I myself have worked with medical anthropologists, sociologists, behavioral scientists, statisticians, data scientists, health economists, communication scientists, people that study organizational functioning. All of these areas of expertise are very important when it comes to implementation science. So this model helps understand the difference in the traditional translation pipeline, where a new intervention is first developed and tested for feasibility and acceptability, and then tested formally in randomized efficacy and effectiveness trials. So during this phase, the focus is very much on whether the intervention works, right? Does it work in a controlled setting? Does it work in a real world setting? And then we get to this space of dissemination and implementation studies, where the focus is, it's on this yellow box here. The question here is, how does the program work, right? What are the strategies needed to make it work? And it entails exploring things like what can help with the adoption and implementation of the innovation, right? And eventually ensuring its sustainability. The real world evidence and the potential benefit to the public increases as our research efforts incorporate implementation and dissemination research and don't just end up with an effectiveness study. Unfortunately, this is where a lot of studies end. You do an intervention, you have an innovation, it's worked, but it never really goes much further. So I really like this recent article by Jeff Curran, and I'm gonna tell you about a talk that Dr. Curran gave in our recent webinar series from the Texas Institute for Implementation Science, where he talks about hybrid designs, which I'll briefly mention, but since he gave an excellent talk about it, I think it's best if I leave you with that resource, then you can listen to his talk. But he talks about I really like the way that he kind of simplifies what implementation science is and what we're trying to do with implementation science. And he says the intervention or practice or innovation, whatever it is the thing, right? That's the thing. And effectiveness research looks at whether the thing works. D&I research looks at how best to help people do the thing, right? Whether it's a practice, whether it's a policy, whether it's a program. And implementation strategies are the stuff we do to try to help people do the thing, right? So, and implementation outcomes are how much and how well are they doing the thing. So, I know this seems really simplistic, but I like it. And one of the reasons is because for people new to the field of implementation science, they often get confused about, well, what is the intervention and what is the implementation strategy? And even for people who have much experience in the field, there is this debate about whether something is an implementation strategy or whether something is a multi-level intervention, and we can get into more discussion about that. But it's important to understand that when we talk about health promotion interventions or clinical practice guidelines, those are the thing. And then what we're doing to make sure it gets adopted and implemented, that's what we call the implementation strategies. And I forgot to mention, I am going to leave time for questions at the end. So as you're listening to the talk, if you want to type in some questions into the chat, I'm sure that we can field those questions. Here's another graphic that actually Dr. J.D. Smith presented just the other day. And it just highlights that implementation research has a different emphasis in clinical research or from traditional public health research. And that is that in effective research, you're emphasizing the intervention, and then the system to support the adoption and delivery is sort of in the background. Whereas in implementation research, you have the intervention and hopefully you have some evidence that it works, but you're focusing on the system to support the adoption and delivery with fidelity. And so they both are included in both types of research. Of course, you have to have a way to deliver an intervention, even in an effectiveness study. And of course, you have to have an intervention to deliver when you're studying the delivery. But it's where these are placed, that where the emphasis is placed, that makes it a regular effectiveness study versus an implementation study. So there's common aims when we do implementation research, and they typically are trying to understand the barriers and facilitators to implementation, adapting an evidence-based intervention, evaluating the impact of an adapted intervention, selecting or developing or adapting implementation strategies, evaluating them, either evaluating the feasibility or acceptability of these strategies or evaluating their impact, and also sometimes comparing different implementation strategies and evaluating the impact of those. This slide shows differences in clinical and public health research from implementation research, right? So the aims, for example, of clinical or public health research are focused on testing an intervention or a health promotion strategy or policy. And in implementation research, it's testing an implementation strategy to get these used. A typical intervention in clinical or public health research is either a drug, a procedure, a prevention program, but in implementation research, it's an organizational practice change or a training. Typical outcomes are for clinical or public health research are symptoms, health outcomes, patient behavior, whereas in implementation research, they're adoption, adherence, fidelity, level of implementation. And then the typical unit of analysis of randomization can be the patient or the community member in clinical or public health research, whereas when you're doing implementation research, it's typically a clinic or a team or a facility or a school. So what can be implemented? There are various types of, when we talk about evidence-based interventions or innovations that can be implemented, and they can include clinical practice guidelines, clinical innovations like a new cancer screening technology, cancer prevention educational programs can be implemented, policies can be implemented, and then there are sort of general strategies like the strategies that are listed in the guide to community preventive services, the community guide. Those are all things that can be implemented. So let's look at an example from HPV vaccination research. Because we use the term implementation strategies to mean what can be very different approaches, I think it's important to take a look at how we're understanding strategies or interventions to increase HPV vaccination uptake. And why is it even important to do that? Because differentiating these terms is important because the evidence bases are different, right? And they may require unique considerations for adoption or adaptation or implementation. So basically, you can implement HPV vaccination guidelines. You can also implement general intervention approaches for increasing HPV vaccination, like in the community guide. They say things like enhancing access, increasing community demand, and provider or system-based interventions. These are the categories of interventions or general intervention approaches that are in the community guide. And you can also implement specific evidence-based intervention programs that have specific protocols and materials. This is a framework from Enola Proctor that a lot of people use that features important elements of implementation science. So for example, when we usually do research, we usually talk about effectiveness research or efficacy research, where we have something that we're trying to evaluate, right? And we're trying to see its impact on health or health status, sometimes behavior. But what's in between really is what we're talking about when we're talking about implementation. How is this evidence-based intervention delivered? What are some of the implementation outcomes? Was it feasible? Was it acceptable? What was the uptake? What was the cost? Sometimes we're looking at service outcomes. And so this is really where the implementation pathway exists. And I mentioned that that Jeffrey Curran gave a really nice talk about hybrid effectiveness implementation studies. And so that's where you actually can have studies that are both looking at effectiveness and implementation. So we know that implementation science then has a focus on producing knowledge about the selection of strategies and how different strategies can influence barriers to implementation. There's also a body of work in implementation science that has to do with developing and testing relevant theories and conceptual frameworks, as well as the measures to assess various constructs within those theories. And but essentially, it focuses on helping to develop effective strategies for implementing evidence-based practices. I would say that last one is sort of the crux of it, and then the first two are how we get there. So there's been a lot of resources in the last decade or so. The field now has 2 journals dedicated to implementation science, 3 textbooks, probably more, 2 major conferences, and D&I science is being prioritized by many organizations. There's also many funding agencies who've made D&I science a priority, and this includes NIH, AHRQ, Robert Wood Johnson Foundation. Just in a couple weeks, the 2020 D&I conference is going to be held virtually for the first time. The Society for Implementation Research Collaboration is another one that is really an excellent one. And specifically for cancer control, I would point you to this resource, Advancing the Science of Implementation Across the Cancer Continuum, which is an excellent resource that talks about many of the issues that we're going to be talking about today, but obviously in much more detail. So since I was asked to give an overview of implementation science as it relates to cancer control, I thought that it would be important to at least touch on some of the primary theories and frameworks and models in implementation science. And we're not going to have time to go into many of them, but I'm going to hopefully give you a flavor of the types of constructs that these models and frameworks entail. So first, there's a lot of variability in how people use the language, right? Theories and frameworks and theories, and there are differences. Theories represent a systematic way of understanding events or behaviors by providing interrelated concepts and definitions. They're abstract and broadly applicable, so they're not content specific and they're not topic specific. Frameworks are strategic or action planning models that provide a systematic way to develop, manage, and evaluate interventions. But the difference between frameworks and theories is that while theories hypothesize and in fact have demonstrated relationships between the constructs within that theory, frameworks are more like categorizations, and they don't necessarily explicate the relationship between the constructs within that framework. So sometimes we start out with a framework and then we do research to see what the relations are between the constructs, and it ultimately becomes theory. models is a term that has been used to describe both, so collectively describes frameworks and theories. So why are they important? They can help you provide a systematic structure for the development, management, and evaluation of interventions and D&I efforts. They can inform the selection and development of essential strategies. They can help with your interpretability of your findings, provide guidance about what you should measure, provide explanations about why something might work or not work. And there are lots of opportunities to advance our understanding in the field of implementation science by actually studying and providing evidence about some of these relationships. So there are many, many frameworks and theories. And Per Nielsen wrote this article some years ago that I thought did a really good job in categorizing them. And he categorizes these sort of three areas: theories that describe or guide the process of translating research into practice. And those are just kind of general process models, kind of like the one I showed earlier that showed efficacy to effectiveness to implementation. Other ones that are for understanding or explaining what influences implementation outcomes, and those are often referred to as determinants theories. And they include determinants frameworks, classic theories, and implementation theories, and then evaluation frameworks. So I'm going to give you an example of some of these. The first one is what we might consider an evaluation framework, because it helps us determine what are the impacts of a particular intervention. And so REAIM is one of the most widely used frameworks in implementation science, and it was developed by Russ Glasgow and colleagues. And it's an acronym for reach, efficacy or effectiveness, adoption, implementation, and maintenance. So in my work with cancer control, intervention, implementation, I often define my outcomes in terms of REAIM. So what is the proportion of the population that has been reached with the intervention? Is the intervention effective among those it reached? To what extent has an organization adopted a program or a policy or a practice? How is it being implemented? And here we're looking at things like fidelity and acceptability, level of implementation, and then maintenance or sustainment. Oh, sorry. Another framework is the Consolidated Framework for Implementation Research, which was created in 2009 to coalesce multiple implementation theories into one framework that contain the important constructs. So it's considered an overarching typology to promote implementation theory development, sort of meta-theoretical, a synthesis of existing theories, if you will. And it's broken down into various domains, and each of these domains contains several constructs. So, for example, intervention characteristics, there's constructs such as the relative advantage of an intervention, is its complexity, the design, quality, and packaging, and the cost. We know that all of these things influence whether or not something is going to be implemented. And then there's the outer setting, which includes things like patients' needs and resources, whether there's peer pressure or external policies that are influencing an organization to implement a program or a policy or a practice. And then there's inner setting, and inner setting includes things like structural characteristics, networks of communication, the culture of that organization or implementation construct. And then there's also characteristics of individuals and process. These are all various domains within CFR. So I just wanted to give you an example, a cancer control example of how we developed and adapted a measure. So we developed a measure of inner setting characteristics, and the reference is down there. Originally we were focusing on colorectal cancer screening, but then we adapted it for HPV vaccination and looked at it in pediatric clinics. And we looked at specifically some of the factors within the inner setting that influence whether or not a program is adopted and implemented. And those include things like culture and leadership engagement, et cetera. And what we found was that the measure worked really well. It had good structural validity, reliability, and we're looking at how those factors influence the implementation of the program and also HPV vaccination ultimately. I'm going to speed up a little bit because time is going fast and I want to make sure we have time for questions. The interactive systems framework is another framework that is used a lot, and it basically talks about these three different systems, the need for synthesis and translation of knowledge and evidence so that it's usable, the importance of a support system that's going to help provide resources and support for implementation, and then the delivery system, which focuses on those individuals and systems that actually put something into practice. And from the interactive systems framework, I've done a lot of work with Abe Wandersman and the Wandersman Center in the sort of conceptualization and measurement of organizational readiness, which here R equals MC squared means readiness equals motivation times capacity squared, capacity, innovation specific capacity, so that's the capacity to deliver a particular thing, do a particular thing, and then general capacity, which pertains to the aspects of organizational functioning, like those things we were just talking about in CFR, like culture and climate and staff capacity, leadership. So it's been really interesting work, and we currently have an R01 where we're developing and validating a measure of organizational readiness. And the idea here, though, is not just to develop a measure, but to develop a measure so that we can build readiness within organizations to be able to better implement programs, and in our case, cancer control interventions. So, there's an assessment phase, they get feedback about that assessment, and then we implement strategies that are specific to what they need, because not every organization needs the same thing in terms of being ready to implement something. So these are just some questions that you might, someone might think about when they're trying to select a model or a framework, and we'll share this presentation so you'll have these with you. But I'm going to switch now to talk about implementation strategies. And there's a lot of different definitions about implementation strategies, but probably the last one here, the methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical program or practice. And I would expand that to say public health program, health promotion program, policy. That's sort of how it's defined. But it's important to know that when we talk about implementation strategies, they're not just a single action or process. Most of them are multifaceted, and they can include a combination of multiple strategies. And sometimes there's actually a packaged approach that is considered a blended strategy. So ERIC strategies, the term ERIC comes from expert recommendations for implementing change. And this was a series of articles by Byron Powell and his colleagues where they looked at the literature and they tried to put these strategies, a lot of different implementation strategies, into buckets, right, and classify them. And these are the different types of implementation strategies that they came up with, right? Strategies that can provide interactive assistance, strategies to support clinicians or engage consumers. And there's a lot of work being done around these strategies, but there's also a lot of questions for them. Unfortunately, it's not enough to have these categories, and there's challenges in selecting implementation strategies. You can't just choose from a list, right? And so part of the reason is that some compilations, such as this one, may be less relevant for certain settings. The strategies included in the compilations are really are broad, and they may represent qualitatively different things. Sometimes they're delivery channels, sometimes they're assessments or processes. And there's limitations in the empirical literature that describe these strategies. So in any case, even though there is a list of types of strategies, there's also challenges in how do we match or select the right strategies for our implementation effort. This is an article that Byron and I and others participated in. That's a research agenda about implementation strategies, basically saying that we need to better understand mechanisms, we need to improve the description, tracking, and reporting of those strategies, we need to increase economic evaluations, and importantly, we need to enhance methods for developing and selecting and tailoring implementation strategies. Most people agree that it's basically a two-step process when you're trying to select implementation strategies. You conduct an assessment of factors that influence implementation, right? And you can use some of those models that we talked about to help inform your inquiry to try to understand why would this get adopted, implemented, and maintained? Why might it not? What are some of the barriers? And then you develop and select strategies to address them. Well, unfortunately, it's not that easy. It would be great if it were, but it's not. And so what do we need to do? Well, there are a number of ways that you can get to that point of selecting a strategy. And in this article that I was not involved in, Byron Powell and others selected some, and one of them that they selected was intervention mapping. And some of you have heard about intervention mapping. We've certainly used it in planning our interventions as part of the outreach core for the U54. But essentially, there's three ways that intervention mapping can be used to advance implementation science. And one is the way that we've used it already, which is designing multi-level interventions in ways that enhance its potential for being adopted, implemented, and sustained. And part of that has to do with the phenomenal community engagement work that the team in Puerto Rico have been able to do, and to ensure that whatever we develop is relevant for the real world. Another way that intervention mapping can be used is in designing implementation strategies to influence adoption, implementation, and continuation. And that's what we call implementation mapping. And that's what's most relevant for this talk. We also can use it for adapting existing interventions. So recognizing that even though intervention mapping had always had an element of planning implementation, I realized that in the implementation science world, it really wasn't known and people weren't really using it. And so last year, we published this article on implementation mapping, using intervention mapping to develop implementation strategies. And I have to say that it's really been phenomenal. This particular article has gotten more hits and more downloads than all of the other about 155 articles that I've published over my entire career combined. And I think that represents the gap that was there, right? The need that was there in terms of we need help. You know, the field needs help in planning implementation strategies. It's not that easy. It's not enough to just understand what went wrong. And so I'm not going to have that much. These are the tasks for implementation mapping. This is sort of a model that shows how there's an evidence-based innovation that we're trying to get used, right? And then we're trying to develop these strategies to get it used, and these strategies influence the determinants of adoption implementation, which then influence the outcomes, which ultimately influence the health and quality of life outcomes. And then the tasks of intervention implementation mapping are along here. So I know we didn't have much time to talk about that, and I'm sort of speeding things up, but I think the article is a good resource, and now there's several other articles that have applied implementation mapping in their work, and that is also a really good example. This is a framework that we've used in a a project that we are working on to increase implementation of colorectal cancer screening best practices and recommended approaches, where it shows how you can use implementation mapping as a way to develop implementation strategies and an overall implementation plan that incorporates some of these theories and frameworks that we talked about earlier. So we used the interactive systems framework and social cognitive theory. We used stakeholder input and organizational needs assessment to inform the implementation mapping process to develop these strategies. So strategies like practice facilitation, EHR optimization, telementoring using ECHO, so use of champions. These are the strategies that that we're going to be using to influence increased implementation of colorectal cancer screening. In this project is with federally qualified health centers. So there's lots of opportunities for D&I research. These are just some of the ideas of things that need to be done. There's a lot of work that needs to be done in the area of adaptation, of how do we best design interventions for dissemination, how do we increase sustainability, how do we scale things up, what about de-implementation, what about stopping something that's no longer useful or effective, and several other areas. So I'm going to leave you with these resources. There's many opportunities here. These are some of the training programs that exist. There's measurement tools. As I mentioned, there's textbooks. The field has really grown tremendously in the last 15 years, and I'd say it's accelerating as well. So in summary, implementation science can help bridge the gap between cancer control research and practice by building actionable and pragmatic knowledge base to help understand why things are getting adopted and implemented and used, and why they're not. Building knowledge about the models and frameworks that can help us understand these relationships and help us know where and how to intervene. And probably most importantly, developing strategies to accelerate and improve the use and the scale up and spread of effective cancer control research innovations. So I will end there, and thank you very much. I'd like to acknowledge these other folks who provided some slides. Sorry, went through that too fast. Let me just go right back to that.
Thank you, Maria. We have time for questions, so you can either unmute and bring out the question and put it on the chat. So any questions for Maria?
Hello, I have a question. Is a way to maintain sustainability in our investigations after we do the collection of data, when we find the answers of the communities and evaluating that so we can sustain education processes? That was the thing we are doing in the investigation, or how we can maintain that? Because I know a lot of investigation, we don't go to that part yet. So they stay in the first part.
Yeah, and we encourage, when we train our students to develop interventions in the first place, right? And think about their implementation. We try to encourage people to work with existing infrastructures for the delivery, right? So if a study team is the one that's delivering an intervention, when the study is over, it's difficult to imagine how that intervention is going to continue. But if you develop an intervention, and maybe the study team has to implement it the first time, especially if it's an efficacy study, because you want everything to be controlled and you want to make sure that it works first. But once you have evidence that it works, an effectiveness trial might try to incorporate the delivery of that intervention with existing infrastructure. So if it's in a clinical setting, it might be the health educator that already works there. It may be incorporating the local health department or infrastructures that can be maintained. It may be through the American Cancer Society or other groups that have an existing infrastructure that even when the study is over, it's going to be maintained. But I would say that one of the best ways to ensure that you're going to have sustainability over time is to engage stakeholders from the beginning, including the stakeholders that are going to be responsible for delivering and maintaining that intervention. So when we do implementation mapping, for example, we ask questions about who's going to be responsible for implementing this program and who's going to be responsible for maintaining it over time, and what do they have to do, and what are the resources and tools that they would need to be able to do that. So planning for sustainability and planning for implementation, I think, should be an integral part of planning for any intervention. But certainly if it wasn't done in the initial development and testing of an intervention as part of a research study, which it often isn't, certainly when you're thinking about sustainability and implementation, that it can be done afterwards.
Thank you.
Next question. You can write it in the chat or unmute your phone, your Zoom. Any questions for Maria? Maria, I would like, while we wait for another questions from the team. I think one for us, since we are including implementation science in our research, one of our current challenges is we have a huge amount of data, qualitative data primarily, while using the CFIR model. And now it's up to us to condense, understand the data, but also disseminate in peer-reviewed journals and with our colleagues in conferences. So it's, and we come to the dilemma in which way to present the data, organize the data, of how further we move the data in terms of analysis. Should we leave it only in pure qualitative analysis, or should we conduct other analysis that, as you presented some of the papers, have done very elegant analysis and quantitative analysis as well. So is there any guidelines on that, or how should we develop that stage, crucial stage for research?
And you're talking about data related to implementation, like what influences implementation?
Correct.
Is that, yeah. So, you know, if particularly if, but not only, but particularly if your inquiry was guided by, in some way or informed in some way by CFIR. But even if it wasn't, there's some really good resources on the CFIR website. So Lara Damschroeder and her colleagues have done some incredible work, really interesting approaches with qualitative data, where they're looking at where the way that it's coded can actually show relationships, or it can help demonstrate relationships between some of these constructs and implementation outcomes, right? Even in qualitative data. And so I would encourage you to look at that website. I think it's cfir.org, because there's a lot of resources, and there's even like guides, but there's also help with coding and stuff like that. I would say that there's still so much that we don't understand about, in particular, the relations between various constructs. So for example, how does an organization's leadership influence communication, or so some of the constructs within those domains, like how do they relate to each other, and where should we intervene? Because obviously we can't do everything. you saw how comprehensive the CFR is, for example. You can't intervene on everything. So it's really important to know what are the important mediators as well as moderators to implementation outcomes. And so I think that having the data is great. And then the challenge is, what is the question that I'm going to ask of that data? And then what is the best way to analyze that data? And I think that there's some really good guidance on that website. I'm happy to talk to teams that are struggling with that for any particular effort, because sometimes it depends on what the question is and what the effort is, what the approach you might take. I can tell you in our work with right now in the R01 that we're working on with organizational readiness, the goal is to develop a measure, like a survey, right? But we wanted to make sure that the survey that we were starting with was one that captured the most important elements of organizational readiness. And so we did in-depth interviews. And like happens a lot, it's this huge amount of data and we don't have time because we need to move forward with the survey development. So we basically took two approaches. We did a rapid analysis, and then we did to help inform further survey development. And then we're doing a more in-depth traditional thematic analysis. And so there's some really nice approaches for doing that kind of rapid analysis of qualitative data when you need some quick answers. But I still do think that an in-depth analysis can be really helpful to try to understand the relations between some of these constructs.
Great.
So I hope that answered.
I did answer. I mean, there's it's an active science that we need to continuously get informed, and those resources that you provide are very, very important, and we will share it with the audience. And since we are just on time, just to let you know, guys, the webinar, it was recorded. We will share with you the webinar, the slides, and the resources that was shared by Dr. Maria Fernandez. Please follow us at Facebook, the Puerto Rico Outreach Program, and we will also include the presentation there. And you can follow also other webinars that are gonna be part of this series. So with that, we thank you, Maria, for today's presentation, and thank you all for your time. Have a great afternoon. Bye-bye.
Bye. Thank you.